Thank you so much. I'll be just telling you about a study done by effect of postnatal monitoring on identification and treatment of high-risk cases to reduce maternal mortality and morbidity. The topic of the project was decided on the basis of providing quality care to mothers in the postnatal period so that the causes of maternal morbidity and mortality are identified on time and the same can be reduced so that the mothers are saved from preventable causes of morbidity and mortality. A large hospital in New Delhi delivers around 6,000 babies a year. In 2013, 5 women died after delivery, and they decided that they wanted to do a better job of identifying and managing women with complications after delivery. After using an interactive approach to improve their system, they are now providing better postpartum care to mothers and babies, and no women have died in the postpartum ward in the first 8 months of 2014. This case study provides lessons that can be used in other hospitals to improve postpartum care and for others learning to use quality improvement methods. A big hospital in Delhi provides care to a largely low-income population, including slum and resettlement colony dwellers, unskilled laborers and migrants. The hospital has 124 doctors, 125 nurses and 46 paramedics. The 50-bedded obstetrics and gynecology department has a bed occupancy rate of over 100%. 16 doctors, 30 staff nurses and 4 auxiliary nurse midwives provide around the clock services and deliver about 6,000 babies every year. In 2013, 5 women died in the postpartum ward of Bhagwan Mahavir Hospital, including 2 who died in December. The Bhagwan Mahavir Hospital staff wanted to improve their system for providing good postpartum care. As there was no readily available information when women were to be managed after delivery, the first thing the improvement team did was to collect data on how often they were assessing women in the first 6 hours after delivery. The Government of India's guidelines suggest that women should be seen 11 times, but they found that women were only assessed twice. As the hospital has load of 500 to 600 deliveries per month, the data of all the patients were taken. To increase the frequency of assessments, the improvement team asked the Deputy Medical Superintendent to issue a letter to the labour room and the postpartum ward instructing nurses to assess women 6 times in the first 6 hours after delivery. 1 week later, the improvement team met again. They found that women were now being assessed more than 6 times. However, the labour room nurses had interpreted the letter to mean that they should keep women in the labour room for 6 hours after delivery. This led to a lot of overcrowding. The team congratulated the nurses on increasing the number of assessments and clarified that women could be discharged to the postpartum care ward where the nurses there would take over the assessment. Between February and June, the number of assessments stayed at 6 to 7 in the first 6 hours. However, the team was not collecting data on how many women with complications were identified and managed. Because of this, it was not clear if they were improving care or not. When they reviewed their records, they found that 2 women, that is 0.1% out of the total, were identified with postpartum danger signs during the last 5 months. 1 woman had eclampsia and other was in shock due to blood loss. Both were managed appropriately and discharged from the hospital. The infrequent identification of women with complications and the fact that both were diagnosed so late likely means that many more women were being discharged home with early but unidentified complications. The quality improvement team met again to discuss how to improve care. Since they were now more experienced in improvement methods to date, they did 3 things differently. Spending time to identify root causes, using small-scale testing to learn what works, and focusing on the patient. The team spent about 30 minutes discussing the root causes that were making it hard for them to identify women with early complications. The main problem was that they were spending a lot of time walking around to find the assessment equipment and to find the patient. So they decided to eliminate the walking. They then set up the observation room and tested it for 2 days. It worked well and the team made a second change, partnering with patients. The nurses in the observation room educated women and their relatives about common danger signs and told them to call the nurse if needed. This improved the efficiency as patients and their families were thus brought in a resource to identify the complications. What was the analysis? After the reorganization of the ward, 5 women, that is 1.6%, were identified with danger signs in this 4-week period, 2 of which were picked by the relatives. All were identified early, managed appropriately, and discharged within a week. The team was happy with their progress and they decided to keep measuring how many women were being identified with complications and to stop measuring the number of assessments. In the following 4 weeks, 14 women, that is 2.7%, were identified with complications, treated appropriately, and discharged home. The reference of the study was taken from University Research Company for United States Agency for International Development, Applying Science to Strengthen and Improve Systems Project, Institute for Healthcare Improvement, Johns Hopkins Center for Communication Programs, and WIHER LLC. Thank you.